So my goal is to help you identify autism spectrum disorders, and I'm going to want you to identify them even before it's autism, and I'll get into that. The relationship between autism and epilepsy, and I'll talk a little bit about the data that we have in regards to Dravet. And then I'm going to spend time talking about what specifically we should be thinking about in terms of the management and treatment of children who have both autism spectrum disorders, social cognition deficits, and epilepsy. So really the essence of my talk is this. We're going to talk about Google, we're going to talk about Facebook, we're going to talk about FaceTime, and we're going to talk about the developing brain. It's a different way of thinking about autism spectrum disorder. I figured that since people don't like to hear about it, when I speak to families, when I'm faced with this, is I like to talk to them about what's really going on, what's happening in their child in terms of social cognitive function. And I think it's very important to think about it from a neurological perspective, what social cognitive function means and how it influences brain development, and not just think about the criteria that were created by the psychiatrists using DSM-5 to talk about labels such as autism spectrum disorders and other developmental disorders. Labels have an importance. Labels are important tools to get the right interventions. But to use those tools, to use that label to get the right intervention, you have to understand really brain development. And it's different than just classifying and giving a diagnosis. So when we think about Google, we think about IQ, or how we can process information, so how quickly you can get facts. And facts is something that we can do, and many people who are very good at getting that information and using that, like learning mathematics, good with numbers, good with just general facts. And you can Google anything and get the facts for it. But that's very, very different than Facebook, right? Because in Facebook you have to make social network connections. So you have to be able to use your non-social cognitive skills, your processing skills, and put them in appropriate social context. And so this, I think, is really at the essence of autism spectrum disorders. What it's taught us is the importance of social cognition to non-social cognition, and as such, to the developing brain. And then I use FaceTime because really what FaceTime is about is really intervention. When we have FaceTime, the interventions that we do for children with autism spectrum disorders are really, at this point, more based on behavioral interventions, educational types of interventions that help change the developing brain. Now, we do have some medications that treat some of the symptoms, but really, when we're treating the process of an abnormal social cognitive developmental trajectory, at this point, we really need to understand some of the behaviorally based, educational based interventions and the importance that they may have, especially early on in development in terms of changing outcome or the developing brain. So really what we're focusing on today is really this other side of epilepsy, right? We have epilepsy syndrome, and the epilepsy syndrome here is Dravet, and that carries with it a whole bunch of different other problems, as we've heard. And in addition to that, we know that the etiology, so in this case we know the etiology can also influence the different things that come along with a particular epilepsy syndrome, or the different neurobehavioral problems that come along with it. And then, of course, the developing brain ages over time, and so things are going to change. And these things have to be taken into account, if you will, as we think about what we're looking at in terms of the epilepsy being more than just the seizures. Clearly, what we're realizing in general is that cognition is an important part of the epilepsy phenotype, and it's an important part of Dravet. We've heard about that. We know that in general, cognitive impairments, learning problems, attention and behavioral problems are present at the start of the first seizure or antedate the first seizure in nearly 50% of all children with epilepsy. In children with epilepsy, cognitive impairments and decline really reflect the severity and dynamics of underlying brain pathology, or the degree that this very distributed neuronal network is affected by the underlying etiology. Very, very similar to when we talk about autism spectrum disorders and use the word spectrum, right? And the same thing in the sense that there's a very distributed neuronal network that accounts for the behaviors that we see in autism spectrum disorders and some of the social cognitive deficits that are part of it. So when we think about the relationship of epilepsy to autism, we actually started out not looking at autism in children who started out with epilepsy. We really, the big interest of this, 20 years ago, 30 years ago already now, was why did children with autism develop epilepsy so commonly? And it turned out that, children with epilepsy, children who started out with autism developed epilepsy in a much higher percent than the general population. And this is a meta-analysis that shows that, in fact, 21% of children with IQs less than 70, and if you go into really low IQs with IQs less than 40, it's as high as 46% of children with autism spectrum disorders end up developing epilepsy. But even in children without intellectual disability with autism, 8% of them have epilepsy. And when we look very specifically at a very recent study which had a very, very high end of 5,850 children, the average prevalence of epilepsy was 12% and reached 26% by adolescence. So there's a couple of things that's happening in the developing brain of children with autism that I think are important, have important lessons as well for the relationship between epilepsy and autism, and as we think about treatment, that in fact, age and cognitive ability or the major factors that are associated with epilepsy. And as children with autism get older, even into the second and third decades of life, they continue to have increased risks of epilepsy. So as we think about epilepsy and autism spectrum disorders, the way that I think about it is that they're disorders of large-scale neural networks with alterations in both cortical and subcortical connectivity. One of the things that we know that they share in common is alterations in mini-columns and selective spasticity of GABAergic interneurons. In addition to that, and this is not really well known, in children with autism spectrum disorders, as is very well known in children with epilepsy, they have abnormalities in neurogenesis, neuronal migration, cellular disorganization, heterotopias, and dysplasias. Again, the same types of things that we see anatomically at a microscopic level in children with epilepsy. And when we look at the circuitry in children with social cognitive deficits, and this is from an article in Schizophrenia, but it's really an article about, it's an article that's really about social cognition and the importance of social cognition. And this diagram really shows the extended network that's involved in emotional regulation and face perception, voice perception, and how we take affect and really process it in the brain. And if you look at this very distributed network, you could see that, again, the overlap between the neuronal network involved in epilepsy and the neuronal network involved in disorders such as autism spectrum disorders is very large. And so the fact that these disorders coexist, we have evidence that they do, and that in fact they share mechanisms, if you will, that can lead to both epilepsy and to autism. And frankly, intellectual disability is a very important part of the phenotype in both disorders. And so understanding this triad, understanding the process of epileptogenesis and the process of what really sociogenesis and what really makes you social, how you develop social cognition becomes an important concept in regards to understanding how we're going to treat these disorders in children with epilepsy. So how do we identify autism spectrum disorders? Well, we have these criteria, and they're the DSM-5 criteria for autism, and they include really a checklist of deficits in social communication and a restricted repetitive patterns of behaviors, and then we have other criteria. Let's look at them a little bit more specifically. The major one is the social communication and social interaction across context, and you need to have all these types of deficits, all three of the following: deficits in social emotional reciprocity, but that can be very, very different in terms of depending on how your intellectual disability, your IQ, is in regards to how it modulates your ability to have social emotional reciprocity. So you could be completely aloof and not really connected to anybody, or in fact, you can actually be sometimes inappropriately social. So like we heard earlier, these children who, with Dravet, who may walk and say hello to everybody, that in fact is a story that we hear as well in very high-functioning individuals with autism, that is, individuals with autism who have a good IQ. They are overly friendly. They're not understanding how to regulate that social emotional component. And then the same thing is true for deficits in nonverbal communicative behaviors used for social interactions. There's a wide range of those that are dependent from having no friends, or really not even having an interest in having friends, to being able to want to have friends but not knowing how, and doing better with adults than with your peers. Which again, we heard earlier on, is something that in the survey that was done in Dravet seemed to resonate among many families. So again, I think we need to keep an open mind when we think about autism spectrum disorders and not really pinpoint it to one aspect. It's really a combination of factors, and they have a wide range of qualitative behaviors and social interactions. And then this whole other deficits in developing and maintaining relationships beyond those with caregivers. One of the things about children with autism spectrum disorders from a social perspective is they really do care about the people who are taking care of them. They really do. And it's really that sometimes they don't understand how to use their social skills in with others, if you will, outside of the realm that they're used to. And then the other group that you need to have to really make a diagnosis of autism spectrum disorder is you need to have this restricted, repetitive patterns of behaviors and interests. So we heard about perseveration in the survey that Dr. Knoop was talking about. And again, perseveration is a very, very common component of autism spectrum disorders. In fact, a lot of the behaviors that are described without making a diagnosis of autism in children with Dravet, and a lot of the things that are called autistic traits, are really just part of the diagnostic criteria that are used if you really look at these in terms of hyper or hyporeactivity to sensory input. So different textures, different foods may affect them, and their fixated interests, whether it's Barney or whether it's something else, and it changes over time. So these are all parts of the behaviors that we see, and we use them to make the diagnosis of autism spectrum disorder. Understanding, of course, that at the center of how we make this diagnosis is really the social cognitive function. Then there's a couple of other things that I want to point out, that the symptoms must be present early in development, but they may not become fully manifest until the social demands exceed the limited capacities or may be masked by learned strategies in later life. So that is, if you're smart enough, you could actually learn how to be social. We usually don't teach that, but you can learn how to be social. So sometimes these children are missed. We'll see some of the studies that have been done in epilepsy and autism now, looking at the more subtle aspects of social cognition and the importance, again, in recognizing them. And then, as any one of the developmental disorders, look, we don't make a diagnosis a medical diagnosis, unless the deficits are clinically significant. That is, they're impairing social, occupational, or other areas of current functioning. So if you can function and you don't have a problem, then you don't have a problem. But if these limitations of your social cognitive skills and your repetitive, restricted behavior and patterns of interest are interfering with your life, then it's a problem that could be addressed and should be addressed. So social skills are a warning, really. They're a warning not only, in young kids with epilepsy, they're also a warning in adults with frontotemporal dementia. So one of the things that we all need to do is be able to kind of think about what other people are thinking and act appropriately. So when a conversation is carrying on, there might be social indifference because you can't keep up with the conversation aspect that is going on from a social perspective. You are really limited in terms of the subjects that you're interested in. There's also an importance in social cue perception, is understanding how to act in different social situations. And then one of the most important ones is experience sharing. A lot of times we look at children and we say, but look, they're playing really well, They like toys. They really enjoy what they're doing. How could you say that, they don't play or they don't have that they have autism? Well, it's really not about just playing with the toy. It's really sharing that experience. And that's a very, very important hallmark of social cognitive function. And you could see it very early on. And I'm going to stress a little bit about why that's important in terms of when we start thinking about interventions. And then managing the emotional reactions to others, how do we control affect, again, an important part of social cognition. So social cognition, which is at the center of autism spectrum disorder, is rather complex, has a huge neural network, and cannot be defined just by one part. But I think it's an important concept that we really need to pay attention to in epilepsy. And it includes processes used to perceive, encode, store, retrieve, regulate information about other people and ourselves. So it can influence academically how you do in school, because you might be able to do very well in school, but if you think it's not important to turn in your homework, then that's an issue. Or if you don't know how to use the information that you've learned in other settings outside of where you've learned them, that's an issue. Or if you're not interested in sharing the information that you have with others, that's an issue. Okay? So we can see these things very early on in terms of a social cognitive developmental trajectory. So just as we think about motor development and we think about language development, as neurologists working with children with developmental disorders, we need to be thinking about social cognitive development and the trajectory and recognizing early on if something is off. So affective reciprocity, 0 to 6 months, that connection between child and parent, looking. It's not just whether they have eye contact, are they using that eye contact consistently? When they've gone into schools and they've looked at children with autism look at other people. And they just like a lot of other kids. But when you measure in a controlled way how often they look at the teacher and look at relevant social information compared to other children, it's less. So you may not see it, but when you measure it, it is less. Joint attention, which I said to you is the hallmark of social cognition in many ways, is the ability that a child has to share their excitement of something with others. So a child doesn't play with a toy just to play with a toy. The first thing they do is look at the parent, look at the toy, look at the parent, look at the toy. They want to share that excitement. They want to know, hey, is this cool? Okay, and that becomes an important part of that social cognitive development. And then theory of mind or metacognition, the ability that we all have to read each other's minds. So as we're having a conversation, I'm trying to look out there and see how many people are getting bored, and you're kind of reading my mind saying, well, where's he going with all of this? And so we kind of get in each other's minds as we think about it. Very, very important. And semantic pragmatic language or social communication disorder, I just put that because when we think about the conversational aspects of language, we're not talking about language anymore. We're talking about a social skill, right? So a conversation is the ability to stay on topic and keep those topics according to how it's functioning within that conversation. I'm not sure what happened there, but let me turn the other one. Oops, went to the beginning. Okay, now how do we diagnose? If we look at it, autism is almost, I think now the prevalence is just as common as epilepsy. It's about 1 to 2% of the general population, that's the prevalence. Are we diagnosing it too much? Sometimes we are, but it's just like epilepsy. Sometimes we miss it. In fact, we miss it quite often because we look for that that seizure that is a seizure as opposed to just some of the symptoms that could be a seizure. Now in epilepsy, we have EEGs and we can look at the EEGs. Well, I'll show you. We have some tools that might be helpful as well for those of you interested in looking a little bit further into this. But when we think about it, the parents are one of our best tools. They begin to be concerned about this at about 15 to 18 months. Now it is true that if you start on with an early onset epilepsy, what you're concerned about is epilepsy. You're not concerned about the other behaviors. But it's interesting to me. I'm seeing more and more parents with young children with epilepsy who are coming and saying, you know what, we kind of were aware that something was going on very early on, but everybody was so concerned with treating the seizures that we kind of didn't look at the other aspects, and that may be appropriate. But again, it's that raising awareness that I think becomes important at recognizing this early. The first complaint, usually, it has nothing to do with behavior. It's really a language. Parents see that their child isn't developing the language skills. And when we talk about language, we're not talking just about words. We're talking about everything that precedes language, and we'll get into that in a second. The common age of diagnosis still to this day is 3 to 5. And my goal is to have you diagnose autism spectrum disorders before it's autism spectrum disorders, because I think that's when we can intervene. Now, we have excellent tools that we can use to be very, very specific at diagnosing autism. We have the Autism Diagnostic Interview, the ADOS, and we even have a scale now that is the Autism Scale for Infants, Observation Scale for Infants, that you can use as early as 6 months, and it has reliability at 6 months, at 12 months, and at 18 months, and it's being used in studies, and I'll show you how it's being used, and you can get a diagnosis. And you can make this, you can use these scales even as low as IQs of 40. So it's not just IQ. You can separate out intellectual disability from autism. And there's an importance in that, as I'll discuss, and I've started to discuss, in terms of the importance of social cognition in the development of general cognitive function. Now, when we look at screening tests, I can actually tell you that you can screen for these things very easily in your office as a neurologist. You have several questions that you can ask. You can ask, does your child respond to his name consistently? Very early on. Does your child point? Right, these are all part of this checklist that's been developed. Just asking if your child's pointing. Does your child, again, share their interest with others? So the point here is that there's very simple questions that we can incorporate into our neurological interviews as we're talking to parents that can give us very significant clues about social cognitive development and the risk for developing autism spectrum. So in recognizing autism spectrum disorders in epilepsy, the goal is to recognize atypical social cognitive development early, before it's even autism spectrum disorder, officially by the diagnostic criteria, to determine who is at risk for poor outcome. Because if we diagnose autism, sometimes it's not enough. I mean, we might know that a child, is at risk for autism, but what we're really interested is, are they at risk for poor outcome? And that's, again, where this relationship between autism and epilepsy becomes very important, because we have good evidence that if you have epilepsy and autism together, your outcome is really poor. And so that becomes important as we start thinking about how aggressive we're going to be in terms of interventions. And then again, intervene early before it's autism. What's the relationship between autism and epilepsy from the literature? Where we know that about 32%, in this one study, 32% of children just screened back in 2005 in a tertiary clinic were screened positive for autism. In a pediatric neurology clinic in Japan that was published in Brain Development, out of 519 patients, 15% met criteria for autism spectrum disorder. In this study in 2012, 37% of 65 children, average age 2.5 years, screened positive for ASD. And 20% of children with new onset and established epilepsy in a clinic, this was in Chicago, they had actionable, they had things that people could do something about from a social, cognitive, behavioral, developmental perspective. And then in the most recent study here from pediatrics, there was 21% of 85 children with active epilepsy had autism. So we didn't start looking for autism and epilepsy till more recently, till the years 2000. We already were looking at epilepsy and autism, but these studies show us that, in fact, autism exists in epilepsy if we look for it, right? But the problem is that sometimes we just don't look. And this is now a nationally representative population with a large N in adults above the age of 16. 8.1% of these individuals with epilepsy had a diagnosis of autism spectrum disorder. Very, very similar to if you studied a population of individuals with autism and looked at their rate of epilepsy, what the rate of epilepsy would be, independent of IQ. In this study, which I really think was very important because it really looked at social cognition in children with epilepsy in mainstream education. So these were children who really were functioning well academically, had a normal IQ, and again, when they looked at this, they found that in fact a significant proportion of these children had impaired social cognitive skills with deficient pragmatic skills compared to their peers without epilepsy. And then if we look at the Connecticut epilepsy cohort, which gave us tremendous data regarding epilepsy, Ann Berg and myself went back to that cohort and looked at how many of those kids retrospectively met criteria for autism. And since this was in Connecticut, we actually had really good data. There was good data there because it was very close to Yale University, and Yale New Haven had always had very good screening for autism spectrum disorders. And in fact, in that population, 5% in a community-based population met criteria for autism. 10% of those whose seizures start in the first 2 years of life. 13% of those with IQs less than 80, and even 2.2% in those with normal cognitive abilities. And then the important point, which again is important when we think about disorders of early onset epilepsies like Dravet, is that in West syndrome, which is infantile spasms, 30% of children with infantile spasms go on to develop autism spectrum disorder associated with intellectual impairments. But again, there may be important lessons there from a management perspective. So this was also the classical studies of Samuelson from Iceland, first looking at epilepsy and then seeing how many of these kids with epilepsy in the first year of life develop autism. And again, 7% of 84 children with seizures in the first year of life were diagnosed with autism, all with intellectual disability. And then they had an N of 6, and 35% of 17 children with infantile spasms were diagnosed with ASD. They all had other little etiologies, but they weren't very significant etiologies to account for this. How often do autism spectrums occur in Dravet? When I looked at the recent literature, I just did a search as I was preparing for this talk, and in 2011 there was a published paper with 9 of 37 kids met criteria for autism spectrum disorders. There was a paper that was done in which Dr. Dravet was involved with, in which in fact they didn't test for autism per se, but they felt that they did a cognitive and adaptive evaluation, and there was attention deficits in this group, inhibited impulse responsive, perseverative responses, and they felt that socialization was higher than communication. But then again, 2 recent studies in 2015 by 2 separate groups found that in fact when they looked at it with scales looking specifically for autism spectrum disorder, in fact it's a lot higher than people think, 65% and 60%. And so I think, you know, there's something there that we need to look at a little bit closer in terms of the relationship in there. The basic premises of of this relationship is that autism spectrum disorders and social cognitive deficits are associated with epilepsy throughout the lifespan. Children with an epileptic encephalopathy, such as infantile spasms, are high risk for developing autism, and the social cognitive deficits that precede autism may be recognized in the first year of life. In epilepsy, the likelihood of developing autism is higher with those with intellectual disabilities. So in the more severe epilepsies, which carry along intellectual disability, that's much higher. And so when we think about who, how, and when to implement behavioral communications and educational interventions, I think we know that this relationship is very strong, so we need to be very clear about identifying these children in very early on. So let's talk a little bit about the management of and how we can conceive how we're going to be able to treat autism, if you will, within an epilepsy population. So a very common way of thinking is that there's an etiology that leads to epilepsy and frequent spikes, and that causes the cognitive regression and the autism spectrum disorder. I actually have given you some data thinking that in fact there are shared mechanisms that do both, but there are probably circumstances. One might be electrical status epilepticus, in which in fact the etiology that led to that could lead to cognitive regression and then could lead to autism spectrum disorder. In that case, you know, kind of treating the etiology besides treating the epilepsy, which we do very aggressively, may be very important. In the classic concept of epileptic encephalopathy, we've always thought that it was the seizures or the epileptiform activity itself that led to the behavioral abnormalities, as such led to the autism. But some of the recent evidence is actually showing that there are common genes, if you will, that are associated with both epilepsy and autism, and as such, that those genes may affect the circuitry of the brain that causes both of these disorders. And a recent study looking at whether aggressive treatment or early on of infantile spasms could change developmental outcome once you've treated the seizures in children with infantile spasms. It showed that, in fact, it didn't affect the outcome of autism spectrum disorder. So as we think about this, it may not be enough to treat the seizures, and we may need to think about what else we can do in regards to kids with epilepsy and their cognitive development. Another way that we can think about it is, do we need to treat the etiology that leads to the epilepsy and the ASD? That is there one common etiology that leads to both? And there's a lot of evidence for that. And I think that's a lot of this is coming from the world of tuberous sclerosis, where early on you can see children with tuberous sclerosis develop the epilepsy early on, in which almost 80% of them do. And as this study by Jesty showed, very early on, even before the epilepsy is occurring or the abnormalities in the EEG, the autism spectrum disorders or the symptoms early on at 6 months of age are already beginning to develop in the kids who then go on to develop autism. So that relationship may be that, again, there are common mechanisms with both, but it's interesting that if we recognize it very early on, not only treat the seizures, but use some of the techniques that we have to treat autism, we may make a difference as well in development. And then these are just also important to realize that the deficit of SCN1A can induce cognitive impairment without seizures, and there are children with autism who have SCN1A and don't have seizures and just present with autism. So there's something about the gene here that is very interesting as well. So the way that I like to think about it is that I don't think that we need to really get hung up on treating the etiology, but in fact, I believe that the etiology leads to a process. And the process that we know about and are talking about as epilepsy people or epileptologists is really the epilepsy or epileptogenesis. We treat the seizures, but what we want to get to is eventually treat the process that caused the seizures, and we're beginning to develop some medications for that. I propose that there's also a process of sociogenesis. That's what I mean about identifying that abnormal social developmental trajectory early on. And I actually propose that, in fact, it's plausible, we have no data yet, but that if we can improve social cognitive function, that may also have a better effect as well, potentially even at the level of the seizures. And there's been some animal data on that in regards to how, how effective appropriate social interventions in a rat model could help in terms of controlling seizures that, we can't get into. But I think it's clear that what is happening in Dravet syndrome is not just a consequence of the epilepsy. There's something else going on, and we need to recognize the fact that treating the seizures is not going to be enough. So if treating the seizures is necessary, but to improve developmental outcomes, it's not sufficient, right? That's what I think we know. So in treating autism, we have a lot of medicines. It's like treating seizures, if you will, in some ways. We can treat the behaviors, but we're not treating the autism. And we do have randomized controlled trials looking at these medicines. Not as many as we do in epilepsy. The outcome measures that we have are very different. In epilepsy, we can say how many seizures do you have at point A, and then it stops, how many seizures do you have at point B? And so we could look at that very, very clearly. Measuring development is much harder, and the developmental endpoints become very, very difficult because there are many variables involved. But it can be done. It's being started to be done, and I think that that's an area that's important. But it's, again, these medications in autism, what we've learned is that the treatment of these behaviors that define autism are necessary because they allow us to put in behavioral interventions, but they're not sufficient. So one of the things that we know is that early intervention for children with autism spectrum disorder, even under age 3, which, remember I told you, that's the common age that they get diagnosed, but we now have multiple studies showing that, in fact, even under age 3, there are interventions that are behaviorally based that can improve outcome. The question in front of us, which nobody has done yet, is can developmental-based behavioral early intervention improve developmental outcomes in epilepsy syndromes? That's a question. We don't know that, okay? But we haven't looked at it, and we haven't done yet such a good job. We can stop the seizures, but we can't improve development. So I think this is a question that we need to pay attention in the field of neurology. So I'll just give you a little introduction about what I'm talking about from a behavioral perspective. A lot of people have some knowledge of this, but again, sometimes a little knowledge is not enough in terms of understanding what we mean. What we're really talking about here is early intensive behavioral intervention. It's a highly structured teaching approach. It's a well-established treatment for ASD. It's rooted in the principles of applied behavioral analysis. And applied behavioral analysis, ABA is the word everybody uses, but it's really just a science of understanding how changes in the environment affect human behavior. So it's everything we do as a parent with our typical developing kids. Johnny throws something on the floor. Johnny, don't do that again, okay? So, and then they learn. So it's a structured way of teaching appropriate behavior, which we do. They just, in autism spectrum disorders and in children who have social cognitive deficits, we need to do it much more structured, much more intensely, and much more frequently. But that's the basis of it. It's specific teaching procedure referred to as discrete trial training. It uses a 1-to-1 adult-child ratio. It's implemented either in the home or in the school settings, and it's pretty frequent, 20 to 40 hours per week. This is where the label becomes important. A lot of people shy away from the label, but in the state of Florida and in many other states, I don't know each of the particular states, I can't tell you that, but in the state of Florida, there is a law that if you have a diagnosis of autism spectrum disorder and you have a private insurance company that is based in the state of Florida, they have to pay for this, which is $40,000 to $60,000 per year. Okay, so including Medicaid. So this is important use of the label, right? Because we can get these services and start them out early on. So why not? If it can work. It's a tremendous use of resources, but it can make a difference. It's the new terminology, because we're getting away from ABA and we're starting to think about implementing these same techniques in natural settings, involve the shared control between the child and the intervention person, using natural contingencies, and using a variety of behavioral strategies to teach development appropriately, improve requisite skills. There are over a dozen established programs with different names that do the same things. And some of these programs are parent-mediated programs. You teach the parent how to actually change those behaviors. And it's very effective. Very, very effective. How effective? I'm just going to give you one study. This was a randomized controlled trial of intervention for children with autism using one of the models of many, the Early Start Denver model. Geraldine Dawson and Sally Rogers and others looked at a group of 18 to 30 months old. They had two groups, one which was the intervention group using the Early Start Denver models, 20 hours per week, behavioral developmental intervention, plus parent training, plus community interventions. The other group just got about 10 hours of community interventions, speech and language, occupational therapy, maybe a little bit of behavioral intervention, but not to the intensity and the frequency of this program. What they found was improved cognitive skills. IQ was raised by 17 points. How do I account for this? I am accounting for this, I think, because social cognition, as I talked to you about, is so important in general cognitive function. So this is important. Adaptive skills improve, but not the repetitive behaviors. Okay, so we know that, this isn't all. So now we have to think about what are the other methods to do that. And diagnostic status changed. It wasn't like you got a cure. We're not looking necessarily for a cure here. We're looking for change, just like we're looking sometimes for reduction of seizures from every day to just once a month. A follow-up study using the same model found that after 2 years of treatment, the toddlers receiving the treatment, the ESDM group, demonstrated an EEG pattern based on an alpha to theta ratio similar to that of typically developing children. So in fact, we changed the brain. They changed the brain, right? They changed that neuronal network. They increased cortical activation, and so maybe by viewing faces. I think that the proof is really in how these kids did, more in some of these, but these are important studies to show that in fact, the neural networks, there's something going on there that is beginning to change over time compared to controls. So this EEG pattern did relate very nicely to gains in social behavior. So current available pharmacological and early intervention treatments of the behaviors that define autism and pharmacological treatments of seizures are all necessary, right? These are, to me, this is now the new standard of care. But to improve the developmental outcomes, I still think they're not sufficient. I think we're going to have to go even further than that and start thinking about some of the new things that are going on. And this, again, now we're entering a new, almost science fiction realm of thinking, but in fact we're talking about these things and we never scientifically were able to talk about this. But now in this excellent article by Chris Walsh in Annals of Neurology, he actually put forth the pathways by which we can think about therapeutic opportunities for treating intellectual disability. So thinking about this, and now there are animal models where we can see we can treat the seizures. And in fact, the social deficits get better as well. So they are beginning to see that. We can see that there are certain pathways that we can begin to think about, like the mTOR pathway, where in fact, it won't only treat the epilepsy, maybe it'll also help us with the social cognitive function. So now this may not, again, be absolute, but now we put it on top of everything else that we have on board, and we may be moving forward in a much more positive direction. And this is already moving forward. We aren't doing this with Dravet yet, but these are all disorders where we know the gene, we know that they are associated with epilepsy, we know they're associated with autism, and we are now identifying some potential treatments, including IGF-1, by the way, which we heard earlier was interesting here. So in the Shank gene abnormality, that's being tried as a trial right now. It's a clinical trial. So I think there are important lessons here as we broaden our perspective and we move forward. We must think about a comprehensive treatment approach to ASD and epilepsy. We need to think about treatment protocols in epilepsy that modify, enhance early social cognitive developmental trajectory, and we need to combine some of these early intensive behavioral interventions with mechanistic-based pharmacotherapy, or as we heard from Dr. Miller, non-mechanistic-based pharmacotherapy. Thank you very much.